Welcome back. Following on from the previous lecture on inflammation, we're now going to take a little bit of a look at the pharmacology of inflammation and some of the medications that can be used to, if you like, have an impact when there's an inflammatory process taking place. Now, as we said, inflammation is primarily a protective mechanism. The area goes red, there's swelling, there's pain, etc., there's heat. All of these are warning signs that something is not right. However, if you have a chronic inflammation, like rheumatoid arthritis or lupus or something like that, it can be advantageous to dampen that response down. If you know it's there and you know what's causing it, what's the value of continuing to experience it? And that's where your anti-inflammatory medications come in. So they would be used when the inflammation is prolonged, when there's a reaction, or if it's an autoimmune disease like the ones we've spoken about, like RA and LSE. So, when there's cellular injury, you get an inflammatory response. And the substances are released to reactivate various enzymes. And the enzymes then produce factors that mediate the inflammatory mechanism, the inflammatory response. So for example, if you look here, there's injuries to the cell. Phospholipase 2 gets converted to arachidonic acid, and arachidonic acid gets converted to leukotrienes, but it also gets converted by COX-2 activity, which is cyclooxygenase 2 activity, to the endoperoxides, which then get converted onto the prostaglandins and thromboxane. And as you'll see there, when you look at the prostaglandins, vasodilatation, vascular permeability, edema and pain. The part of the whole kind of process and outcome that you experience with inflammation. So what you can then see is, if you can stop the production of prostaglandins, you can minimise some of the consequences of an inflammatory mechanism. So the way to do that could be to block cyclooxygenase 2, to block the COX activity. So cyclooxygenase, that enzyme, exists in two isoforms, possibly three, COX-1 and COX-2. Cyclooxygenase is a constitutive enzyme that's present in most tissues, and COX-2 is an inducible one. This is the one that's induced during inflammation. And this is the one we're going to be focusing on in terms of our anti-inflammatory pharmacology. So COX-2, as we said, produces prostaglandins that are pro-inflammatory. And then that produces, as you saw in the diagram, pain, because the prostaglandins sensitise the nociceptors, vasodilatation, and you get a rise in body temperature as well, because the prostaglandins act on the hypothalamus, and that in turn produces the alteration of the set point of our body's temperature. The first class of agents we're going to look at are the ones that are referred to as the non-steroidal anti-inflammatory drugs, the NSAIDs. So, they inhibit the cyclooxygenase enzyme, therefore they prevent the production of the prostaglandins and the leukotrienes. So you don't get the prostaglandins being formed at the same level, therefore you don't get the same responses like the vasodilatation, etc. Examples, probably the best known example of a non-steroidal is aspirin, acetyl salicylic acid, or ibuprofen is another one, but not paracetamol. I've only got that in there. You're probably well aware that non-steroidal anti-inflammatory drugs do not include paracetamol. But it's incredible how many people make that assumption, because for general everyday pain relief as an analgesic, people tend to use aspirin or paracetamol. Therefore, they assume that every action of the two of them is the same. Yes, they're both analgesic, but only aspirin is the non-steroidal anti-inflammatory. This is not an anti-inflammatory agent. So, if you give a COX-2 inhibitor, like a non-steroidal drug, anti-inflammatory, you will get analgesia, but you will get, more importantly, an anti-inflammatory action. Exactly what the name says, non-steroidal anti-inflammatory drugs. And it also gives you the benefit of an antipyretic action. And that's because the prostaglandins that are being produced are sensitizing the nociceptors, activating inflammatory mediators, and readjusting the thermal set point in the brain. By blocking the prostaglandin production, you get analgesia, anti-inflammatory, and antipyretic actions. And this is just a little table here showing the relative specificity of ratio of specificity for COX-1 to COX-2. What you can see then is the ones down here, you're getting into the realms of, at one extreme you've got the drugs that have got a greater level of specificity, and at the other end you've got the ones that have a much lower level of specificity. And that's important, because if your drugs affect both COX-1 and COX-2, you're more likely to see adverse side effects than if they are COX-2 specific. So the analgesic action, how does it come about? Basically, you decrease the sensitization of the pain receptors by blocking the production of prostaglandins. And you can give them alongside opiates. They can be very useful in headache when the headache is caused by an inflammation. So that's what they do. The nociceptors would normally be activated by prostaglandins. You prevent the production of the prostaglandins. And this is just a little diagram to show you that basically what we're doing is these fibres down here are the A delta and the C fibres. The A delta fibres are large diameter fibres that are myelinated. They're sending fast pain signals. And then you've got the C fibres, which are small diameter, unmyelinated. They're sending slow pain signals. And we'll actually look at those fibre types in more depth in a few lectures' time when we talk about the pain pathways. That is the sending of the pain signals up to the brain. We'll come back to that. The antipyretic action is that they reduce fever. How do they do it? They block prostaglandin production in the hypothalamus. Which prostaglandin specifically? Prostaglandin E. There may be other mechanisms involved, but that's the primary mechanism. So the prostaglandins in the hypothalamus no longer adjust the thermal set point, and therefore the fever that's been raised by the inflammatory mechanism is now lowered back down. Anti-inflammatory action, look back at the slide at the beginning. You block the cyclic oxygenase 2, you reduce the production of the prostaglandins, which are the inflammatory mediators, therefore you get an anti-inflammatory action. You'll see there popular uses of aspirin: arthritis, headache, and body ache. Just the general aches and pains in the middle there. Now, up the top's the heart disease. That's because aspirin is also antiplatelet aggregation. It stops the platelets join together, therefore reduces the likelihood of the blood clotting. The dose that does that is significantly lower than the dose that will have an anti-inflammatory, antipyretic, and also analgesic action. You're probably looking at about an eighth of the dose does this. These, though, are various aspects where there's an inflammatory response potentially, particularly in headaches and certainly in arthritis, and therefore that's what aspirin is more commonly used for. They do have side effects, though, and we will come on to those in a lot more detail in the latter part of the module. We'll look at these side effects and explain why. But basically, the prostaglandins that are being produced in the body, if you remember back earlier on, we said that some of them are kind of constitutive They're always there, they're doing a job in the background, and others are inducible, they're switched on in certain pathological conditions like inflammation. Well, there are prostaglandins that, for example, the GI bleeding, the gut bleeding. The gut is an acidic environment, so what protects the lining of the gut from the acid? The cells of the gut, prostaglandins are produced there, and what the prostaglandins do is, the prostaglandins produce bicarbonate solution, which neutralizes the acid at the stomach wall, therefore stops the acid in the main body of the stomach and the GI tract from burning through the wall. If you block cyclooxygenase, you block the production of prostaglandins there as well. You get therefore the acid environment activates and antagonizes the lining of the stomach, and you get GI bleeding. Prostaglandins are also essential for maintaining renal perfusion. Don't let the prostaglandins form, you don't get adequate renal perfusion, blood supply to the kidney goes down, you get renal impairment. So there's various things there, and we're going to come back and talk about them again when we revisit the non-steroidal anti-inflammatory drugs and look at them as more of an analgesic agent in a later lecture. Now, just when we mentioned paracetamol, there's a lot of debate and discussion goes on about paracetamol. It's not an anti-inflammatory agent, so it's not any good for that, but it is a widely used pain medication. But in the UK, in recent times, they've limited the number of tablets that you can buy. It used to be you could go to your pharmacist or supermarket and buy paracetamol in bottles of 100 or 200. Now you're limited to 32 tablets. 32 500 milligram tablets in any one purchase, and that's because of the toxicity. So, if you've got too much paracetamol in the blood, it's almost like the main metabolic pathway is being swamped and can't deal with the volume, the amount, the concentration of paracetamol that's there. So you start to then switch on minor pathways. And these minor pathways work on the paracetamol and produce intermediate metabolites. This toxic one, N-acetyl-P-benzoquinamide. And what that does is, that has to be metabolized further to get a non-toxic metabolite. However, if you get too much of the drug, you exhaust the supplies of glutathione, you can no longer then take the toxic metabolite and make it a safe metabolite, so the concentration of the toxic metabolite builds up. And what it does is, it starts to bind to proteins in the liver, and that causes lipid peroxidation. And that lipid peroxidation in the liver damages the cell membrane of the cells of the liver. And eventually, if that was prolonged, the cells would break down and you would get cellular death that ultimately could result in liver failure. And that's the consequence of the paracetamol toxicity. So, those are the non-steroidal anti-inflammatory drugs. And we will revisit them and look at them again later on. But what about if there are non-steroidal anti-inflammatory drugs? That kind of implies that there are steroidal anti-inflammatory drugs. And that's what we're going to talk about next. The corticosteroids are probably the main one we're talking about here. They have an anti-inflammatory action, and they also are able to reduce the edema. So, what are the steroids? They are derived from the metabolism of cholesterol. They're produced by the adrenal glands. They are both immunosuppressive and anti-inflammatory. So, there's this immunosuppressive thing. Although, if I think of the example of a cancer patient being going to be given chemotherapy, we know that they can become immunocompromised as a result of their chemotherapy. But at the beginning, when they're starting the chemotherapy, they could have an allergic response to the administration of the chemo. So before chemotherapy is given in that first instance, patients are often advised and given steroids to take to suppress the immune system in the short term to reduce the likelihood of an adverse reaction when the first dose of chemo is given. So they would probably be given a steroid the day before, the day of, and the day after chemotherapy administration. And that's because it has immunosuppressive properties. The steroids are the most aggressive anti-inflammatory agents that we've got. They are much more powerful than the non-steroidals. They don't work by inhibiting the COX, they work by inhibiting the phospholipase enzyme. Which, if you look back at the diagram in the previous lecture, you'll see that that's the one production that's going to result in the production of the arachidonic acid. So, what are we using them for? Well, they're used anti-inflammatory, they're used anti-suppressive, immunosuppressive. So they're used in asthma, rhinitis, eczema, drug reactions, rheumatoid arthritis, organ transplant where there may be rejection, and they can be used in replacement therapy when there's not enough adrenal gland and you're not producing enough of them. The steroids work on a steroid receptor, and steroid receptors are nuclear receptors. That is, they're found inside the cell membrane. Take you back to the earlier presentations, earlier lectures when we spoke about the four main types of receptors: G-protein coupled receptor, ligand-gated ion channel receptor, kinase or enzyme linked, and nuclear receptors. The steroid receptors are that fourth class, the nuclear ones. And what happens is it comes in, binds to its receptor. The receptor then will have an impact on the transcription process to either repress transcription or induce transcription of particular genes. That then results in the increase or decrease in the production of specific proteins, and that's how they're working, they're changing cellular function in that way. So the way that they regulate the expression of those genes at the nuclear level is by they switch some on, they switch some off, but at the end of the day what you get is the change in the genes, and the change in the subsequent proteins results in a net anti-inflammatory action. So what they do is they reduce the production of inflammatory mediators, and they inhibit the production of anything that would, if you like, not inhibit, they would activate anything that would have an inhibitory action on inflammation. So the inhibitory cell migration, so the inflammatory cell migration, they actually inhibit that, so you don't get the cells going there. And they also inhibit the expression of the adhesion molecules. So these are targeting quite a number, and you can see then why they work in so many different places, why they've got a much stronger anti-inflammatory action. So they block it at the level of the phospholipases, and then that's producing that's promoting synthesis and release of lipocortin. Lipocortin is phospholipase A2 inhibitory glycoprotein. So they synthesize and release lipocortin. Lipocortin inhibits phospholipase, and if you inhibit phospholipase, you reduce the production of arachidonic acid, and if you reduce the production of arachidonic acid, you produce a reduction of the prostaglandins. So it's a flow mechanism. So here's the things that the corticosteroids actually do on some of the mechanisms we've already talked about. Some of the inflammatory mediators, IL-1, TNF-alpha, they're all decreased. You get a decreased nitric oxide synthesis, which results in less nitric oxide, which again was implicated. You get the decreased activation of phospholipase A2, therefore you get fewer prostaglandins. They decrease the adhesion molecules, therefore you don't get the emigration because not as many leukocytes adhere. And then you get increased levels of enzymes known as endonucleases, and they induce the apoptosis and switch on the, if you like, the pre-programmed cell death of lymphocytes and eosinophils. As we mentioned, they are also immunosuppressive, and that's because they have an impact on white blood cell proliferation. So they are immunosuppressive agents, and again, they can be used in the maintenance of autoimmune disorders where you want to suppress the immune system. For example, after a transplant, you don't want the immune system switching on, recognising the transplant organ is foreign and switching on a process that would ultimately result in rejection of the organ. Patients who are on long-term steroid use would usually carry a steroid card like we see over here. And that's because prolonged treatment can result in significant damage. You can get a number of different side effects, so it's important for people to know that you're on them. So you can get poor wound healing. Now, in osteoporosis, this is, I'll give you a little case study, an example, a case study of my own father. My dad died a number of years ago now, but he had really significant respiratory problems. He had emphysema and he had bronchiectasis. As a result of that, he had to get heavy-duty steroid given to him as a way of treating the inflammatory mechanisms that were taking place in his lung. Now, when he got the steroid inhalers, he was on them for so long that if he got a wound, it was very difficult to heal. And he also started to suffer osteoporosis in his hips, where he was kind of sitting down so much, he wasn't active because of his respiratory condition. Now, what happened as a consequence of that is, because he had the underlying respiratory problems, he was kind of prone to respiratory infection, which, in order to treat it quickly, they gave him intravenous antibiotics. But when they gave an intravenous antibiotic into the back of the hand, it took a long time for the wound to heal. Over and above that, normally with the osteoporosis, with the pain that he was in, they would have thought about giving him an opiate analgesic for the chronic pain. But if someone's on steroids and they've got osteoporosis and that causes chronic pain, if they're on the steroids for a respiratory inflammatory process, you cannot give them an opiate analgesic because opiates suppress respiration. So you're in that kind of catch-22 situation. So, to avoid systemic side effects, steroids are often given topically or by inhalation. So that's one way of getting around that. You can get them into the respiratory system through an inhaler. But if you had to give them intravenously, you would be more likely to get the side effects. Yeah. If you do that local application or an injection into a joint, that will reduce the systemic effects. So what we've got here then is just that diagram again, showing you the production of the prostaglandins and how the phospholipases are here, and they're blocked by the corticosteroids, the steroid ones, and then the cyclooxygenase is blocked by the non-steroidal anti-inflammatories. And as I said, we will come back to this and look again at the non-steroidals. But at the moment, what you should be thinking about is this kind of process here as your summary slide, and thinking of where the cyclooxygenase inhibitors work and what they do, and where the phospholipase A2 inhibitors work and what they do. Thank you.